Pre-malignant liver lesions. Pre-malignant liver lesions are crucial to identify because they offer an opportunity for early intervention, potentially preventing the progression to hepatocellular carcinoma, HCC, or cholangiocarcinoma, CCA. These lesions typically develop in the context of chronic liver disease and cirrhosis. Definition and conceptual framework. A pre-malignant liver lesion appears benign but has a significantly increased risk of becoming malignant compared to the surrounding liver tissue. Cirrhosis is the primary predisposing condition and is considered a pre-malignant disease state itself. Classification of pre-malignant lesions. Lesions are classified based on their cell of origin and histological progression. The most common pathway is the hepatocellular pathway, which involves lesions arising from hepatocytes. Hepatocellular premalignant lesions, adenocarcinoma sequence. These originate from hepatocytes and progress through increasing dysplasia grades. The key lesions include lesion, pathogenesis and features, risk of HCC progression. Key diagnostic clues: large cell change, LCC, previously large cell dysplasia. Reactive or indeterminate. Enlarged hepatocytes with enlarged nuclei, normal nuclear cytoplasmic ratio. Often seen in viral hepatitis. Its role as a true premalignant lesion is debated. It may be a high-risk marker. Low. Considered more a risk marker than a direct precursor. Detected on biopsy, histology required. Not visible on imaging. Small cell change, SCC, previously small cell dysplasia. True premalignant lesion. Cells are smaller with increased nuclear cytoplasmic ratio and nuclear hyperchromasia, representing clonal expansion. High. Considered a direct precursor to HCC. Detected on biopsy, histology required. Not reliably seen on imaging. Low-grade dysplastic nodule, LGDN. A nodular lesion in cirrhosis with minimal atypia. Approximately 10 to 15% risk of progressing to HCC over 5 years. Imaging often indistinguishable from regenerative nodules, appears ISO/hypointense on MRI without arterial enhancement. High-grade dysplastic nodule, HGDN. Intermediate between LGDN and early HCC, with significant atypia but no stromal invasion. 30 to 50% risk of progressing to HCC within 5 years, often targeted for ablation. Imaging, gray zone lesion, hypointense on hepatobiliary phase MRI, may show subtle arterial enhancement. Biopsy often needed. Beta-catenin activated hepatocellular adenoma, HCA. A benign HCA subtype with WNT/beta-catenin pathway activation. High risk, up to 30 to 40% may harbor or progress to HCC. MRI, atypical, heterogeneous, intense homogeneous uptake in hepatobiliary phase with intracellular fat. Diagnosis via biopsy and immunohistochemistry, GS+, beta-catenin+. Biliary premalignant lesions, intrahepatic neoplasia sequence. These originate from bile duct epithelium and can progress to cholangiocarcinoma, especially intrahepatic CCA, ICCA. Lesion. Pathogenesis and features. Risk of CCA progression. Key diagnostic clues. Biliary intraepithelial neoplasia, BIL-IN. Microscopic, flat, or papillary dysplasia of bile ducts. Graded BIL-IN 1, 2, 3, carcinoma in situ. Associated with primary sclerosing cholangitis, PSC, hepatolithiasis, liver flukes. High, especially for BIL-IN 3. Considered the direct precursor to intrahepatic cholangiocarcinoma. Invisible on imaging, diagnosed via biopsy or resection specimen examination. Intraductal papillary neoplasm of the bile duct, IPNB. Macroscopic, papillary growth within dilated bile ducts. Produces mucin, similar to pancreatic IPMN. High-grade dysplasia or carcinoma often present, 50%. Imaging shows dilated bile ducts with intraductal enhancing soft tissue, MRCP often needed. Mucinous cystic neoplasm, MCN, of the liver. Cystic tumor with ovarian-type stroma, mainly in women. Risk linked to mural nodules and degree of epithelial dysplasia. Large, multiloculated cyst with wall or septal enhancement, no bile duct communication. Diagnostic approach. 1. Clinical context is essential. Understanding the patient's underlying liver condition is vital. Cirrhosis, regardless of cause, is the primary risk factor for high-grade dysplastic nodules, HGDN, and HCC. Specific syndromes such as alpha-1 antitrypsin deficiency, HNF1 alpha mutations, and primary sclerosing cholangitis, PSC, are associated with particular premalignant lesions. 2. Imaging techniques, multiphasic contrast MRI is gold standard. The Liver Imaging Reporting and Data System, LIRADS, provides a standardized framework for evaluating nodules in cirrhotic livers. LR3, intermediate probability, includes many HGDNs, follow-up or biopsy recommended. LR4, probably HCC, may represent early HCC or advanced HGDN. Hepatobiliary phase, HBP, loss is a key feature. A nodule hypointense on HBP, e.g., with EOVIS/GD-OBD-TPA MRI, indicates loss of hepatocyte function, a hallmark of progression from dysplastic nodule to early HCC. Any new or enlarging nodule greater than or equal to 1 cm warrants dedicated MRI surveillance. 3. Histopathology, biopsy. Biopsy is indicated for atypical imaging findings, rapid growth, or to subtype lesions such as HCA. Differentiating HGDN from early HCC can be challenging and often requires special stains, e.g., CD34, GIAS, HSP70, and molecular markers. Management guidelines. Management depends on the risk of malignant transformation and the patient's overall liver health and surgical risk. Specific management strategies include HGDN in cirrhosis, thermal ablation, RFA/MWA, beta-catenin activated HCA, surgical resection, intraductal papillary neoplasm, IPNB surgical resection with bile duct excision, mucinous cystic neoplasm, MCN complete surgical removal. Key takeaways. Cirrhosis is the primary field defect. Any nodule in a cirrhotic liver should be considered pre-malignant until proven otherwise. HGDN represents the most actionable precursor. The transition from HGDN to early HCC is the critical window for curative intervention. High-quality MRI with hepatobiliary contrast is essential for characterizing indeterminate nodules and detecting early HCC or HGDN, especially using the hepatobiliary phase.